We are delighted and privileged to have Dr. Ron Daniels, founder of UK Sepsis Trust and also key frontline medic, to deliver and also talk today about his perspective on critical illness, sepsis and severe infection at this really challenging time. Owen Mitchell's been a long-standing corporate supporter of UK Sepsis Trust and all of Ron's work with his team, and we're proud to support their valuable work over many years. I'm going to hand over to Ron shortly and get things underway. He will start his talk. However, just to mention that if you do have any questions during the webinar, please type them in the Q&A panel on your screen. These will be picked up and Ron will respond to as many questions as he can at the end of his talk. If you want to let me know during the webinar, anything that you need answering, please type that in. Also, just to flag, the webinar is being recorded, so there will be a link sent to you at the end of this with an email. I hope you enjoyed the talk. I'm looking forward to it, and I'll now hand over to Ron. Many thanks, Ron.
Thank you so much for the kind words, Sarah. I've been told I now control the slides, but my toggle is not moving to my beginning slide. So could we try that again, please? Excellent. We're there. So thank you for the kind introduction, Sarah, and more about the relationship between our organisations in a little while. So my background is as an intensive care consultant. And I've been in that role since 2002. And I'm actually very proud to say that I don't work in an ivory tower organisation. I work in a district general hospital where I think we can deliver excellent care from a majority of patients other than those that need referral to tertiary centres. We're going to talk about critical illness in the context of sepsis and severe infection because the object of the UK Sepsis Trust registered with the Charities Commission include improving outcomes from sepsis and severe infection. So more in a moment about what I mean about that. My journey started with the untimely death of this man on the left slide, Jem. Now, Jem, short for Jeremy, was 37 when this photograph was taken, and he was also 37 when 2 weeks later he died in my intensive care unit. His story and his pathway will be familiar to most of you on the call. There were multiple opportunities to rescue Jem, both in the community and in my hospital, that were not taken. So he did not have, at multiple opportunities, complete sets of observations. The safety netting information provided to him and his wife, Karen, was imperfect and often not present at all. And when he arrived in hospital, we became situationally unaware. We became focused on his cardiac arrest, and we failed to stop and think why this fit, healthy 37-year-old man might have suffered cardiac arrest. So we didn't give him what, had they been given earlier, might have been life-saving antimicrobials until 8 hours after his admission. That was all back in 2004, and a lot has changed since then, but I can pinpoint the exact moment when I realized we had to do something about sepsis. And it was a moment I was walking down the hospital corridor behind Karen. And the nurse was walking with Karen because we were about to take her into the relatives interview room for a conversation. Now, the nurse did what nurses do and had her arm around Karen, comforting her. I'd stayed behind for my security blanket, my set of notes, and was walking, I suppose, self-importantly, 10 yards behind. And I noticed Karen's shoulders begin to heave. And at that moment, I just realized the humanity of what was about to happen. I was about to take this young woman into the relatives interview room and tell her that her fit, strong husband wasn't coming home. We were unable to save him because he'd been deteriorating despite maximum critical care support. I knew that she would have to go home in bits and tell Tom and Emily, they're 9 and 6, they're standing on a box in this picture, that Daddy wasn't coming home, all from a condition that I knew she would never have heard of and from a condition that I dealt with on a daily basis. So we started to look at what the scale of this problem is. And when we come on to COVID-19, I think this scale is important. Sepsis, we know, is life-threatening. That's clear. This is the official definition of sepsis for non-medical people. It's a life-threatening condition arising when the body's response to an infection, and that's important because sepsis can be triggered by any infection, but it doesn't require bacteria in the bloodstream. Sepsis can be triggered by a simple UTI, by a straightforward pneumonia, or even an infected cut or bite or sting. In many patients, there are also bacteria in the blood, which we call bacteremia, not septicemia. That's a defunct term. But sepsis is the body's response, largely mediated by the immune system, which damages organs. And we hear in the media about cytokine storm with reference to COVID-19. It's that cytokine storm that also causes organ damage in patients with sepsis. Now, this is Villa Park, the home of Aston Villa Football Club. And one important point I'd like you to take home here is about statistics and how we view statistics. Because looking at this image, most of you will see a crowd. You won't see 42,000 people. You will see a crowd because the faces are too innumerate. And often when we talk about statistics, that's the way they are. But each one here, each face, even though they're difficult to see, is a person, of course, with a life to live, a story to tell, loved ones to care for. There are 42,000 gems in this photo, or 42,000 Karens. Now, to bring this into context from a UK perspective, and we'll come on to the global perspective, breast cancer claims just over 10,000 lives every year, and it's right and proper we continue to improve outcomes from that condition. Bowel cancer claims an estimated 13,000 lives every year, and again, that's improving. And again, it's right and proper we continue to improve outcomes. But sepsis, we conservatively estimate to claim more than 48,000 lives every year, which is more lives than they claim by breast cancer and bowel cancer and prostate cancer, road traffic accidents, and HIV and AIDS put together. So it's a huge problem. But of course, for some patients, these conditions will coexist. Some patients will have had chemotherapy for breast cancer and die of neutropenic sepsis, for example. But it's an enormous and prevalent problem. We don't know quite how big a problem it is, and I'm just going to illustrate that with showing how imperfect the data we have nationally on sepsis are, because they're all rooted in hospital episode statistics. Now, these are only as good as what health professionals write in the medical notes, and most people on this call will be aware that that is often far from perfect. But there are some definite sepsis codes, which are these, and if we look at the hospital episode statistics data for England alone in 2017, there were 200,000 admissions to hospital with one of those conditions. But we know that sepsis is undercoded, and often patients are simply coded as having the underlying infection, even if they end up dying of multi-organ failure on an intensive care unit, which clearly isn't directly a consequence of a urinary tract infection, for example. It's a consequence of sepsis. But most patients, as many as 60% who die of sepsis, are coded only as having the underlying infection. And the most common four are listed at the top there: pneumonia, water infection, an abdominal problem, or a soft tissue infection. So we decided to look at the common codes for those. We did a bespoke analysis of hospital episode statistics data. And if you like, this is the denominator. The it might be sepsis, probably isn't for a majority, but probably is for a number. The denominator population of severe infection patients admitted to hospital for 72 hours or more in 2017 was 1.7 million, which is clearly a huge issue. Globally, this slide illustrates that we only really have data from rich countries. So what we did a couple of years ago is we asked the Institute for Health Metrics Evaluation team over in Washington and in Pittsburgh to do a study on the global burden of sepsis. And with rather alarming timing, immediately before the world became aware that this virus was not going to be restricted to China, that this was not going to be simply another SARS or another MERS, we published. And the findings were startling. And I'd like you to bear in mind that COVID so far internationally has affected around 5 million people, it's estimated, with around 1 million people having recovered and around 350,000 people surviving. The rest, the outstanding 3.5 million people, are yet to recover, and some of them will be in hospital, but some of them will be continuing their recovery journey at home, more on which later. But sepsis each year affects 10 times the number of people that COVID-19 has already affected, and claims more than 30 times the number of lives every single year. I'd like you to remember that when we come on to talking about COVID-19, because of course this is a pandemic, of course this is a crisis, but severe infection claims millions of lives every year around the world, and many of them are children, particularly under 5 in low and low middle income countries. So we have a prevalent humanitarian and, of course, fiscal problem. The World Health Organization takes sepsis very seriously. With another hat I wear is as one of the executive team in the Global Sepsis Alliance, and we presented this resolution to them in 2017, which they adopted. And they said some very important things within this resolution, such as, and again relevant to COVID-19, that sepsis as a syndromic response to infection is the final common pathway to death from most infectious diseases worldwide. And the IHME team support this, and they go on, they count deaths from dengue fever and from Ebola as sepsis, because these patients are dying not with an infection of a single body part, but with a cytokine storm, with the immune system's overreaction, therefore with sepsis. So on a global scale, it's clear to see that sepsis is highly prevalent, claiming more lives, for example, than cancer, according to WHO data. But so far we've talked about life and death, but the reality for survivors can be different, and this is why we are really ramping up our support to people not only who've survived sepsis, but also who've survived and been bereaved by COVID-19 right now, because there is a burden of survival. This was one of a number of studies I could have picked up, and we don't have a lot of scientific slides in this presentation, you'll be pleased to know. But in this study, 17% of people who'd survived sepsis had moderate to severe cognitive dysfunction persisting at 1 year following their index episode. So that means, of course, that they can't return to work at their previous level of function, if they can return to work at all. And when you add to that a 22% incidence of post-traumatic stress disorder in people who've been unwell enough to require intensive care, you can start to see how the loss of self-worth, the loss of self-belief from not being able to work, for example, coupled with the personality changes, the panic attacks, the anxiety, the nightmares that PTSD brings about in all of its formats, you can start to see how our charity on a daily basis deals with people who are losing their jobs, finding it difficult to maintain their relationships, and no longer able to care for their dependents, and are having their homes repossessed. There is no formal funded rehabilitation program on a national basis for patients recovering from any infection, unlike for stroke and for heart attack. So right now, we're working with the Intensive Care Society to begin to plan and deliver that response. Of course, we need funding to support that response. And if you want to help, go onto our website at sepsistrust.org and look for our COVID-19 recovery response pages and donate. And next week, we're going to be launching a fantastic social media campaign, so more announcements on that soon. But we've got to support these people. Around 40% have at least one of physical or cognitive or psychological sequelae persisting at 1 year following their index episode. In this study of working age adults, 57% were back at work at 1 year, 43% weren't. So of course, the economic considerations of COVID-19 as well as of sepsis don't just relate to the expenditure that the state pot has funded to get us out of this, but also points to people who will be sitting at home unable to return to work at their previous level of function, if at all. Rehabilitating these people is very likely to speed that process and get them back to work. So we provide information to people. We provide the knowledge that they're not on their own, that other people are also suffering from these symptoms, which helps. We have expert nurses. We're bringing in psychologists, dietitians, nutritionists to help with this process, as well as physiotherapists. We can't provide direct one-to-one care for everyone who needs it for as long as they need it. That would be unmanageably costly. But what we can do is self-help guides, bespoke resources, online resources, together with using technology to track people's progress and to identify people who are struggling. We had, prior to COVID-19, and we've re-established these in an online format, face-to-face support groups in 33 towns and cities around our country, moving now into Scotland, yet to move into Northern Ireland. We have a fantastic relationship with Irwin Mitchell as one of our key law firm partners. There are a number of partners that we work with. Irwin Mitchell and the Sepsis Trust have had a brilliant relationship from the outset with the sharing of pro bono donation of time, availability of office space when possible. This is a wonderful relationship to us. What we don't do is we don't commit to providing clients to our law firms. And in fact, fewer than 3% of people who interact with our support team end up speaking to a lawyer. And I think we have to see that as a success, much as empty Nightingale hospitals are a success. We're able to help most people. So on to our recovery response. The skills our support team have in supporting people who've survived sepsis are, of course, directly transferable to people who survive COVID-19. The pathophysiological process is almost identical. The length of time in intensive care is even greater with COVID-19 than with sepsis, but is of a similar duration, and these people are likely to be similarly broken. So they're likely to have physical after effects, most commonly fatigue, disabling fatigue, people who can't function for a whole day at work, even several months after their index illness. There's the psychological, which we've discussed, and the cognitive, again. These are about poor judgment, poor memory, poor concentration, all of which can affect an individual's performance. So we typically provide support to people with sepsis, a helping hand, a listening ear. What we're determined now to do with your help is to escalate that to provide targeted rehabilitation to people. To start with, we've amended our earlier literature and we've changed it to a recovery after critical illness resource. Now, these are helpful to people who work within an organization who've been affected by COVID-19, as well as to people leaving hospital. So for anyone who's been hospitalized with COVID-19 or with sepsis, there are resources available to help them and to guide them. I think it's important that we look at some of the national data and the implications of the national data for the bigger picture around COVID-19, because, of course, quite rightly, all focus is on COVID-19 at the moment. So these are data from the Intensive Care National Audit and Research Centre, which captures data from more than 97% of British intensive care units. ICNARC data confirm that we have passed the peak of the first wave. So the first slide there shows that we are starting to see reduced numbers of patients in intensive care, but there's a big lag time between admission to hospital and people leaving intensive care. For the 1% or so of people affected by COVID-19 who require critical care admission, the median length of stay is around 21 days. So there's a big lag time, and that's why often these death figures lag significantly behind the number of people admitted to hospital. We don't make decisions in intensive care until it's certain that someone isn't going to survive. And with every day on a ventilator, those chances of survival to a functional existence diminish. So the next graph is cumulative, and apologies that it's rather small there, but what it shows is that more than 50% of people admitted to intensive care are still in intensive care. And that supports what we've said before. So we've seen nearly 10,000 people admitted to intensive care in England and Wales with COVID-19. Scotland collect their own data, of course. A majority are still there. Around 40% are known to have died. A significant further percent are likely to go on to die, but many are surviving. And in my intensive care unit, we're very proud to say that our survival rate for COVID-19 is 63% at the moment. And that's fantastic. So it's not a death sentence, even if people need intensive care. This rather unfortunate bar chart, it's not particularly attractive, but I didn't draw it, shows that this is sepsis. That 1 in 3 patients have shock, cardiovascular failure with COVID-19. 1 in 3 patients have renal failure with COVID-19. COVID-19 is a viral infection of the airways and lungs. It does not on its own cause shock and renal failure. Those entities are caused by the cytokine storm, the immune system overreaction, and that satisfies every definition of sepsis. So in some patients admitted to intensive care with COVID-19, they develop sepsis, and it's a significant number. This graph confirms what we've heard in the media, but really seeing the figures there starkly. I think what ICNARC have done quite cleverly here is to compare these patients not with patients with normal bacterial pneumonia, which we see 10 a penny in intensive care units, but with the much rarer viral pneumonia. Now, the mortality rates are higher with COVID-19 than for normal viral pneumonia. But the ethnicity here is really interesting, as well as the gender variation. So you can see there's broadly a 50-50 split normally in most conditions between male and female. But in COVID-19, 71% of people admitted to intensive care units in these countries are male, and a much smaller proportion are female. And then if you look at the lower part of this table, normally patients with viral pneumonia broadly represent our demographic split in terms of ethnicities. COVID-19 has torn that apart. And you can see that 3 times as many people of Asian origin than normal are developing critical illness with COVID-19, and 4 times as many people of African origin are developing critical illness with COVID-19. Why? Well, we don't know. There's almost certainly a genetic variation. There will be cultural, lifestyle, and dietary differences between ethnicities that might be partly to blame. Sunlight avoidance has been implicated. Vitamin D has been shown to be protective to patients with COVID-19. But also, of course, people from a BAME background are more likely in general to be undertaking frontline jobs. And that may be part of the problem. We've heard about the socio-demographic index, socioeconomic deprivation. And again, this slide, drawn from data from intensive care units, shows that that's absolutely true. The more deprived you are in terms of your socioeconomic status, the more likely you are to become critically ill with COVID-19. And that's very worrying. It's not a great leveler. I've included this slide really for, well, some hope for those of us that are heading into the 50 age group and above, that this is not a death sentence, that there are survivors in people with COVID-19, even at the extremes of age. And you can see there that if you are under 49, your chance of survival if you're admitted to intensive care is really pretty good. It's 75%, which is similar to the chance of surviving intensive care from all conditions in a normal situation. As you get older, your chance of survival does diminish, but it's by no means a death sentence. So national data in octogenarians show that 37.5% have survived. We should not be seeing people using age alone as a rationale for refusing intensive care admission. That would be wrong. So I'm going to conclude before we move on to questions by talking about what we as a charity have been doing historically, including in the very recent history prior to January, to mitigate against harm arising from sepsis at a national, political, geopolitical level. One of the early things we did was to understand that our USP is in translational healthcare medicine. It's around taking academic guidance and translating it into something that a junior health professional can deliver operationally at the bedside. If you like, it's like making it sexy. It's applying a sales polish to it. So we developed an entity called the Sepsis 6, more on which in a short while, which is a bundle of treatment to be delivered to patients with sepsis before the charity was initiated, and we've developed it with the charity and it's iterated over time. But we identified in the early days of the charity that what health professionals really needed was guidance as to when to initiate this therapy. They'd heard of the Sepsis 6, they knew what it was, but who to give it to, because the international definitions for sepsis were very complex and busy health professionals couldn't carry them around in their heads. So we developed resources with all the relevant Royal Colleges for all patient groups, so adults, for children, for women in pregnancy, because their physiology is slightly different. And we developed tools to empower health professionals to act. And they've iterated over time, but the current versions are all endorsed by NICE. And I'm going to read a question in a minute because it looks important. So we start with the patient looks unwell or has a national early warning score of 5 or above. So the trigger point is using existing national early warning scores that should be applied to every patient in every hospital and increasingly outside hospitals, or your clinical suspicion, your gestalt. As this patient developed a severe illness, am I worried about this patient? We then qualify it with could it be due to an infection, and then we look for the presence of red flags. So we ask health professionals to look for 1 or more red flags. And if there's a red flag there, we empower that health professional to start the Sepsis 6. Now, the key here is empowerment. This is not about saying, you can read there, one of the red flags is a heart rate of more than 130. Now, if you're a moderately experienced clinician and the patient's heart rate is only 128 and they look very sick, That doesn't mean you can't start the Sepsis 6. These are there to empower when a junior doesn't know what to do. So they're a redundancy, if you like, but they've been very well embraced and they're in use in more than 90% of British hospitals now. So if there's a red flag present, we start the Sepsis 6, that question being addressed in a minute. We first developed the Sepsis 6 in 2006. It's now in use in 98% of British hospitals and in 36 other countries around the world, places as diverse as Sweden, North America, Cambodia, Vietnam, New South Wales, and so forth. The Sepsis 6 has spread like wildfire, not because it's clever, but because it's simple and it's empowering. And it's, again, that empowerment of junior health professionals that's been so important. I think that question disappeared, but I will come back to it. And the Sepsis 6 says that what health professionals need to do is, firstly, to get someone senior on their way and then proceed with the rest. Correct low oxygen levels, to get some access and send some blood so we can find out just how sick the patient is, to give the all-important antibiotics. Now, they won't help patients with COVID-19, but many patients with COVID-19 also have a bacterial super infection, and so we tend to prescribe antibiotics routinely if they're ill enough to require intensive care, to give intravenous fluids judiciously, and to monitor the patient. And we've shown with research studies that patients with, sorry, I'm just scrolling down to this question, that patients who receive the Sepsis 6 are twice as likely to survive if it's delivered within the first hour as patients who don't receive the Sepsis 6. So the question that's caught my attention was, how can companies support employees returning to work after surviving COVID-19? Apologies that this is off topic, but this is absolutely part of our COVID-19 recovery response. We would love to work with companies, to work with wellbeing teams, occupational health teams, to support their employees, to design bespoke resources, deliver those resources to employees, and to provide our expertise and support. Of course, we want to do that. We're willing to do that in partnership. There is going to need to be a resource application for that. So back on topic. We're heavily supported by ministers, both by the outgoing health minister and the now health minister. Jeremy Hunt took sepsis very seriously, and he undertook a number of measures. So he mandated that NICE produce a guideline on sepsis, but also the all-important quality standard on sepsis. He also mandated that NHS England establish a national cross-system programme board, and that's been really effective. Commissioning incentives for delivering better sepsis care, so screening for sepsis and delivering antibiotics, have been astonishingly effective. So before we had the sequin commissioning incentive, 32% of people who had sepsis received antibiotics within 1 hour. So it was a bit of a lottery. You had a 1 in 3 chance of getting the right care. It's now more than 80%. And although we haven't measured mortality continuously because there's no national data on this, sequential studies using admittedly different methodologies seem to suggest that mortality rates have appeared to fall from around 30% to around 20% during that same time. So we've improved process, and we have some surrogate measures over the last 5 years that outcomes have also improved for patients with sepsis. Now, the current health secretary obviously is rather busy now, but he does take sepsis equally seriously. He is motivated to use big data support, but he does get us in hot water sometimes by issuing some rather silly statements. Now, sepsis, we've revised the figures over time. We used to say 52,000 years ago. We said 40,000. We then re-estimated to 52,000 deaths. We now say 48 and bit. But he tweeted 52,000 deaths, every one a preventable tragedy. That is simply not true. We cannot save every life from sepsis. For some people who are approaching the end of their natural life, who have degenerative conditions, it might be inappropriate to escalate to provide higher level care if sepsis develops. For some patients, their progression is so rapid that even the best healthcare cannot save them. And that, of course, is best demonstrated by people becoming critically ill with meningitis. If they don't present to healthcare quickly enough, often the clock has been ticking for too long and we simply can't save them. We can't reverse the process. But Matt here got us into a bit of hot water with some academics, and we were accused of hysteria. Now, we weren't directly named in this Lancet paper, but it was claimed that our making so much noise about sepsis was firstly imbalanced. Now, the IHME data I showed earlier have blown that accusation out of the water. But secondly, that incentivization of antibiotic delivery for patients with sepsis has resulted in overuse. And the headline was, "We've doubled the use of antibiotics in emergency departments." So we accessed the same data that these authors had. We had the same data table sent to us by the same individual, and the data was completely misrepresented, and The Lancet probably shouldn't really have published this paper. Because they did show there that antibiotic use in emergency departments had doubled, but what the authors failed to declare was the right-hand column, which the antibiotic use in hospitals as a whole had not changed. So we're changing the geography of antibiotic use rather than increasing it. Patients, as we know, are spending a lot longer in emergency departments than they used to, so they're receiving more care in emergency departments, often 2 or even 3 doses of antibiotics. So we're changing where antibiotics are given, not how many are given. What that shows is it is possible to incentivize better sepsis care without adverse consequence, and we've seen similar data on this from New York State and from Ireland. Back to the WHO declaration. When we wrote an opinion piece on this in another one of the journals, we asked the former Chief Medical Officer, Sir Liam Donaldson, to write a foreword. And he said something really interesting, which we chose to put in and highlight in this, because it's so important. That some very important, and I'm paraphrasing because I'm looking at my camera, not at the slide, some very important clinical conditions, some of them a matter of life and death, exist largely in a backwater inhabited by academics and enthusiasts and professionals, but that the public and political space is the space in which these conditions need to be in order for things to change. And he went on to cite the campaign around HIV, the campaign around cancer and hepatitis. They've all had international political attention applied to them, and that's what's driven change. So we see that as our role. Get it into the political space, talk to the WHO, the European Commission, the Department of Health and Social Care, and effect change in that way, but also to empower our public to know when to come to healthcare. Now, we're a small charity without a marketing budget, so we don't pay for any advertising. But what we are good at is forming relationships. And there are a lot of big, shouty yellow vans driving around our roads. So now 5 of the 10 English ambulance services are sporting messaging around sepsis on most of their newer vehicles. There are 10,000 out-of-hours doctors' cars driving around the country, and across the southeast of England, we also have messaging on out-of-hours doctors' cars. JC&Co, Signature Outdoor, Ocean Outdoor, and other owners of large format advertising space in city centres, as many of you will know, will always have unsold space. And particularly because our messaging, it empowers people to just ask, could it be sepsis, has NHS backing, has NHS support, so it has that all-important Lord John, they're prepared to give us that space. So we campaign across city centres. We can illuminate buildings. This is Birmingham's library. This is the International Convention Centre in Birmingham, shopping centres. We can even illuminate messaging on casinos and across roads. One of the things we've been doing recently is working with Iceland Foods to develop the Schools Against Sepsis programme. So this is a programme with a lesson plan for school children. It's fronted by CBeebies Dr. Range and This Morning's Dr. Range, and it's got a voiceover with Hollywood actor Warwick Davis because his wife narrowly survived sepsis. So it's about telling our school children about sepsis, a responsible attitude to infection, including access to vaccination, including hand hygiene, and including not seeking antibiotics for a cold or a mild illness. So it's getting our next generation responsible. Iceland have been brilliant. They were evaluating what they can do without spending huge amounts of money. And they were already printing, of course, the labels for their milk bottles. So it came to them that because they sell 6 million milk bottles every week, that it would cost nothing for them to change the messaging on their milk bottles to educate people about sepsis. So we've had 6 million milk bottles going onto 6 million breakfast tables, telling them about sepsis, all at zero cost to us and minimal cost to Iceland Foods. I think while we're talking about schools, we ought to talk about this multi-system inflammatory problem that we're starting to see in children. And it's important to reinforce this is a tiny number of children right now. And even in countries like China, which are way ahead of the curve on us, it remains a tiny number. So we're not expecting huge numbers in the pediatric population, but we are expecting to see a number of these patients. So what should we look for? Now, people call this Kawasaki disease. It's not Kawasaki disease. It just resembles Kawasaki disease. The treatment might be similar, okay? So that's get the child to hospital, give them intravenous immunoglobulins and or steroids, and to do that rapidly and in high dose, and the outcomes can be good. But if presentation to hospital is delayed or treatment's delayed, then outcomes can be less good. So what should we look for? Well, these appear to be the most common symptoms and signs that children are developing. They tend to be older than children who develop Kawasaki disease. These are children typically between about 3 and about 8 years, but that's not fixed in stone. Most important thing is trust your instincts. The child looks unwell. They'll be running a high fever. They might have swollen hands or feet or joints. They might look red around the eyes. They might have very sore-looking mucous membranes, the lips, the mouth, and so forth. They may well be breathless. They may well have a cough, but they don't have to have a cough. They're frequently complaining of a sore throat. And you might, if you feel in and around their neck, under their collarbones, you might feel some lumpy glands, some swollen lymph nodes. So there's multiple symptoms. The child doesn't have to have all of them, but if your child's looking unwell and has any one of these, take them straight to A&E. The NHS is still open for business as usual. Other things we do in the space is we've been working with the Premier League, although less so over recent times, but individual clubs have taken this very seriously. So Liverpool, for example, have communicated to a lot of their fans around the importance of looking out for sepsis. We've had a relationship with the Grand National, and thankfully we weren't going this year because we decided to step away. But it's effective advertising when it works. This screenshot was from a television coverage immediately before the race and was seen by 18.1 million people around the world. It cost us about £50 to resize that graphic to fit that particular asset. So very cost-effective advertising. Holby City on BBC One. The programme itself is very much not a documentary. It's very much a drama. It's taken with a pinch of salt, but it's seen by 5 million people every week. And we had a median screen time of 14 seconds across 27 consecutive episodes just for the price of a couple of posters. When Coronation Street approached us to run a story on sepsis, of course we jumped at it. With 8.1 million people watching the programme every week and the story affecting young Jack Webster, who was to survive and therefore is a lasting memory of sepsis in the programme. This just didn't just happen. We spent 3 months reviewing scripts with them to make sure they were robust and that they wouldn't scaremonger. And then we spent a further week on set directing the scenes in the hospital. It was great fun, but hard work, and resulted in a huge number of responses. People who'd watched the storyline, seen their child becoming unwell, and asked that question, could it be sepsis? And probably saved their lives. So we estimate that by continuing to improve the way the NHS responds to sepsis, together with empowering our public to access healthcare quickly when they're concerned about it, and asking that question, could it be sepsis, that we can save a further 7,000 lives every year before COVID came along. Outside antibiotics, the treatment principles for COVID-19 are similar. So we see it as our job not only to support people recovering from COVID-19 with our recovery response, but also to do our part in messaging as to when to get to the hospital if you're worried about COVID-19. So free now to answer any questions, and thank you very much.
Thanks, Ron. That's absolutely brilliant. I can see there are some questions there. I don't know if you want to work through them.
Let me scroll down, absolutely. So that's why I put my glasses on. So I can actually read
I can read them out to you if that's easier.
Yeah, if you have one or two that jump out at you, then yes, please.
So one of the questions is, are there any particular signs and symptoms that differentiate sepsis from COVID-19? i.e., what do we need to do to look out for those?
Okay, so that's a really good question. So the symptoms set in adults for COVID-19, for sepsis, not COVID-19, that we agreed with Public Health England are that if you or a loved one are very unwell with an infection and you develop one of the following symptoms, go straight to healthcare. And they spell the word sepsis. So S for slurred speech or confusion. Now, we're not seeing slurred speech with COVID-19, but we are seeing confusion. So that can be replicated. E for extreme pain in the muscles or joints. Again, patients with COVID-19 can develop that, particularly around the chest wall muscles, but patients with COVID-19 can get muscle pain. T for passing no urine, no water in a day. Well, I've said that a third of patients with COVID-19 have renal failure, and so they can have a reduced urine output. S for severe breathlessness. Of course, COVID-19 causes breathlessness. So we'd advise that people access healthcare early if they're breathless at rest, if they can't undertake the most basic of daily activities like making a cup of tea, or if they find that they're breathing very, very fast, more than twice a second. Either it feels like I'm going to die, and that's the most common symptom reported in sepsis. It's also reported in COVID-19. And then the final S for skin that's mottled or discolored or very, very pale. That can happen in patients with COVID-19, but less commonly than in bacterial sepsis. So the answer to your question is there is not one single discriminator. And what a health professional will be doing is to be looking at the patient. Now, if they've clearly had a very painful abdomen and it's tender when we press it, then we suspect that's not COVID-19. We suspect they've got a burst bowel or appendicitis, and we'll treat as sepsis as a consequence of that. If we do a chest x-ray, if they describe a cough, and we do a chest x-ray and it shows that one lobe of the lung is very densely packed with phlegm, that's probably a normal bacterial pneumonia. But if it's the edges of the lung that look inflamed on both sides equally, that's probably COVID-19, and we'll treat it as such. So I suppose the straightforward answer is it doesn't really matter. The symptoms are similar, but we need to know when to get to hospital. And that symptoms list remains very pertinent in knowing when to get to hospital.
Thanks, Ron. I think what came from that as well, and I'll go back to the questions in a minute, but I've heard you talk before, and are you genuinely concerned that people aren't going to the hospitals and seeking out help when they genuinely need it at the moment?
Oh, absolutely. I mean, I felt so strongly about this that I recorded a video for social media around it to say that we are open for business as usual. We've seen national data that A&E attendances are down by 60%, 60, which is really worrying. Where are all the people who are developing sepsis? Where are all the people who are having heart attacks, who are having strokes? They're either sitting at home and compromising their long-term functional outcomes, or they're sadly dying at home. And we do know that many police forces and fire services have extrication teams in operation right now. So we are worried that people are needlessly dying at home. And that's ignoring the impact of 3 months delay in cancer care, for example. So we always knew that we'd have a sort of first wave of the mortality and intensive care burden, the second wave of the longer term impact on people with other chronic conditions and the impact of cancelled operations, and then the third wave of people who have suffered, and it will only be once this crisis is over, massive emotional trauma. So along with the economic after impact, there is going to be a huge mental health post-pandemic impact.
That leads nicely, actually, onto a question that's been raised. From the information you gave, we know that sepsis survivors need a great deal of rehabilitation. That's not necessarily out there and recognised. Certainly the post-sepsis syndrome isn't hugely recognised from the experience we've had. But it seems that rehabilitation for those suffering and surviving COVID is going to be a significant part of supporting life after COVID. What are your discussions with the government about this? Have there been any, and what are the plans to deal with this future support?
So I think when this crisis first came to our shores, we were reassured by the government that resource would be thrown at it. I mean, I think it's fair to say that that resource has been centred on the immediate surge capacity, on the immediate surge response. Resource has yet to be allocated, and at the moment it seems unlikely to be allocated to the post-recovery period. So we are working with the Intensive Care Society as part of their rehabilitation working group. We are going to partner with that organisation, we hope, to be able to deliver this care. So the concept is going to be that that professional society design, with input from us and other stakeholders, the blueprint for what good support should look like, and it will then be our job to procure resource to get out there and deliver it. So that's how this seems to be going to look. Some hospitals have volunteers providing post-critical care discharge recovery, but they don't involve physiotherapists typically. They don't involve psychologists. They don't involve dietary input. And that's all going to be so important for these survivors. And let's remember that every month we see a similar number of people surviving sepsis as have survived COVID-19 so far. So we shouldn't think that this is only needed by patients with COVID-19. This is an opportunity to develop proper rehabilitation service for everyone who's been critically ill.
Looking at some of the a list of attendees on this call, there's a various range of people, including therapists, OTs, doctors, and lawyers. For those working in the private clinical sector or the NHS clinical sector, so what's your message to them and what support can they offer?
I think it's about evaluating what you as an individual provider of healthcare services can do and should do. It may be that rehabilitation falls outside your remit, but if it does, then we need to understand where to signpost people to. Right now, our support nurses, who are experienced intensive care nurses, can listen and provide information. Our job is to procure resource, including through community fundraising, and again, just to say, our recovery response page is open for donations right now. There will be social media activity next week. But our support team can help right now. What we need to do is to build that capacity, build the skills in to provide rehabilitation. And if there are any people with those individual skills, so this might be physiotherapists, it might be intensive care psychologists, it might be people with neurocognitive or neuropsychiatric assessment expertise, and dietitians, if they would like to contact us, we'd love to hear from them and to begin to build possibly a volunteer base, possibly an employee base, but very definitely an understanding of the skill sets that are going to be needed.
Brilliant, thank you. And another question is sort of leading on from that, but slightly wider. What's the most effective way of raising awareness of sepsis in our communities?
So I think right now we've taken what we hope is a responsible approach to not shouting about sepsis during the COVID-19 pandemic. But as this first wave settles down, as people with other conditions are represented to healthcare, that's the time at which it's important to reinforce to the public that actually infection is not just about COVID-19, that people are dying of infection every day and we have it in our hands to prevent that. So what we'd encourage is to look at what we can do without discretionary application of resource, for example. So if we're in a company, what can our company do? Can we have screensavers? Can we have email signatures? Can we have something attached to pay slips? Can we communicate with our client base? If we're a health professional, what can our practice do? How can I get the information into my patient's hand? Particularly if we're receiving patients who've survived, we need to get that recovery information in. But if we're treating patients who might be vulnerable to infection, to sepsis or to COVID-19, it's important that we give them safety netting information and signpost them to where they can access help if they're worried.
That's brilliant, and there's so much.
Sorry to interrupt there. I think someone mentioned schools. Now, our schools program remains active and live. Obviously, teachers right now are looking for things to do to help their children. So if people would like to look at our Schools Against Sepsis pages on the website, signpost their schools teachers to those pages, then it would be a fantastic way. This is all accessible virtually. We've got the videos on there, the PowerPoint lessons on there, and it's a great little piece of homework for children to do while they're sitting at home, and very timely right now.
I'm sure most parents will be grateful for that opportunity, as well as teachers as well, to introduce something different, part of the science maybe even.
Absolutely. So it's aimed at key stage 2 children, so sort of 9 to 11-year-olds, exactly as part of their PSHE curriculum.
Perfect. Another question's just come through. What information do you have for post-sepsis survivors?
So our Recovering After Critical Illness booklet stands alongside our Recovering from Sepsis booklet, and both resources are equally applicable to people who've survived sepsis. Obviously, the critical illness one also describes some specific information about COVID-19. So they're available, obviously, for free download from our website for practitioners who are dealing with lots of vulnerable people and might be dealing with people who are coming out of hospital who've survived COVID-19. They are available as physical copies through, and they're not obvious, easily navigable to on our website. But if you just look in shop, then those resources are available there. If you want to download them, that's free. Just get on and do it.
Another question, you mentioned obviously the use of antibiotics, and we see a lot of discussion and debate around the overuse of antibiotics. Obviously, everyone's being encouraged, rightly so, at the moment. Clean hands, lots of hygiene. Again, what are your thoughts around that in terms of the long term? Because obviously, no doubt those sorts of comments will come up in due course.
Yeah, absolutely. And, look, we in critical care have been concerned by the amount of antibiotics we've been using during this crisis, but they've been needed. Around 40% of people are developing a bacterial infection on top of the viral infection that is COVID-19. So we are needing to use them. The one saving grace is we're not using many broad spectrum antibiotics at the moment. Most of these bacteria that people are developing are sensitive to relatively simple. But of course, that on its own drives a selection pressure towards the development of resistance. You mentioned the hands, and there was a study out this week that the optimum number of times to wash your hands in a day is 6 times, which is fine. So most health professionals are overdoing it, certainly, but of course we need to protect our patients. To wash your hands many more times than 6 doesn't seem to be protective. But we've seen companies who make cleansing products, their share prices increase. People are becoming, quite rightly, obsessive about hygiene. Now, that's fantastic in the prevention of viral infection during this crisis, but there might be some long-term consequences if that behavior is sustained of reducing exposure to more benign pathogens and reducing herd immunity to coughs and colds and flu and so forth.
I think in terms of it, I can't see any more questions coming through. If anyone does have any more questions, give you another sort of minute or so. Ron, what's the plan for Sepsis, UK Sepsis Trust and yourself going forward? Obviously, I know it's an evolving one, but what's your immediate sort of plan? Where do you want to get to?
Yeah, and I just add to the question, if you've got a challenge, please put it forward there. The questions have been very supportive and collaborative so far, but, there might be something that's burning in your mind as a challenge, and that could well be right and could add to the quality and the value of this presentation. But this crisis has really focused the minds of the Sepsis Trust. I mean, of course, we're a small charity. We only have 22 employees to start with, and we've had to furlough a few who aren't able to contribute at this difficult time. So one example is our brilliant education team who manage our presence at conferences and deliver face-to-face training for healthcare staff. Of course, they haven't been able to do much, and it wouldn't have been right to focus huge attention on online courses for sepsis right now during this crisis. But what it's really reinforced to us, our short-term and intermediate goals, as well as our long-term goals. So short-term is about survival. This really is an existential crisis for many charities. Sector income is down by 80%. And as a charity who traditionally rely upon community fundraising rather than philanthropy and big grants, that's hit us quite hard along with many others. So we do need help. So survival is the immediate, alongside the much needed support, the recovery response to people who've survived COVID-19. From an intermediate perspective, we'd already become aware that support was going to be our biggest growth area in the intermediate future. This has really given us opportunity to strengthen that. And this is about collaboration. This is about partnership with industry, partnership with large organizations, partnership with professional bodies to establish ourselves as one of a number of willing providers of expertise in rehabilitation from critical illness due to infection. And in the longer term goals, at a very top level, what it's really reinforced to us is this is about not only sepsis, but also severe infection. We, assuming we can survive, and we fully intend to survive, can be there as a resilient force for when this next pandemic comes along. In the intervening time, we can provide much needed support, much needed rehabilitation to many thousands of people.
I picked up there, Ron. You said when the next pandemic comes along. Are there any thoughts in relation to that? I mean, is it, definitely going to happen?
We've had some near misses, haven't we? We've had SARS, we've had MERS, the Middle East Respiratory Syndrome. We've had Ebola, which of course containment was successful for. The R value was not quite as high, so we got away with that. But we've had some near misses. It's important to remember for the non-health professionals that this is SARS-CoV-2. So this is a novel coronavirus. There are broadly 7 groups of coronaviruses, of which this is one. Most of them cause pretty mild illnesses, and they can cause some common coughs and colds. Mutations in those viruses can cause problems. And we saw that with SARS. We're now seeing it with COVID-19 as a consequence of SARS-CoV-2. So we've had some near misses. We'll probably have many more near misses before the next big one comes along. But most epidemiologists have been predicting, and in fact, Bill Gates and in fact, Barack Obama were predicting this 10 years ago. We've been overdue this pandemic, and it is only a matter of time. Now, we hope it'll be another 100 years, like the intervening period since the Spanish flu, but it may not be.
Thank you, Ron. I think we need to leave it there. I just want to say a sincere thanks to you, Ron, for delivering such an insightful session. I'm sure everyone will agree. I'm sure you will, all who've listened, found that extremely interesting and useful, and I certainly have, and it reinforces really what a complex and key area this is, and thank you again for the amazing work you are doing at the charity and on duty with all the other NHS staff as well. As a few takeaway messages from this, I think it's clear from what you've said, Ron, we should not ignore the symptoms of sepsis because they need timely treatment. And with that, particularly, survival can occur, and the sooner the better. Also, people should trust their instincts. Seems to be one of the points that's come out of it as well. If you're unsure, go and seek medical help. And if you are in need of support, obviously contact the UK Sepsis Trust team, and they'll obviously help with the huge amount of resources they've got available. So I'd like to say many thanks to you all for joining today's session and for the questions you've all put through. There is on the Erwin Mitchell Coronavirus Hub, which I'd like to direct you to. It's available for you all to access at any time, and it's regularly updated with the latest guidance. We are also hosting future webinars as well, again, which you may wish to sign up to, and these can also be viewed on the Hub on our website page. So please do take a chance to look at that. Finally, do email us at Erwin Mitchell. The events at erwinmitchell.com team is shown on the screen now. If you've got any further questions, any feedback at all from today's webinar, any further questions for Ron, and also any future webinar topic ideas as well. So it just leaves me to say thank you so much, Ron, for sparing your very precious time. Stay safe and hope to see you soon. And thank you again.
Thanks so much, everyone, and good to talk to you all.
Thank you. Take care.